Hey guys, this is Dr. Anjana. Welcome to Gynec 360. Today we are going to see about pathophysiology of pre-eclampsia. It is important to understand this topic clearly as it's examiner's favorite topic. I have compiled a set of important questions that can be asked in and around this topic. Please go through. So let's get started with introduction of pre-eclampsia. Pre-eclampsia is gestational hypertension with proteinuria. So what is gestational hypertension? If an antenatal mother who's more than 20 weeks of gestation comes with a BP recording of 140/90, that is checked after 4 hours and it's still 140/90, and this blood pressure resolves 12 weeks of postpartum, we call it as gestational hypertension. With this scenario, if she has proteinuria, we call it as preeclampsia. So what is proteinuria? Persistent 1 plus in urine dipstick or urine protein creatinine ratio of more than 0.3 or 24 hours urine protein showing more than 300 milligram is considered as proteinuria. So 10% of gestational hypertension can end up in preeclampsia, and 10% of preeclampsia can have normal BP recording. Preeclampsia is classified as with severe features and without severe features. Without severe features is a BP recording of 140/90 to 160/110, whereas with severe features is a BP recording of more than 160/110 or having deranged blood parameters such as low platelets or elevated renal and liver function tests, or having imminent symptoms like headache, blurring of vision, right hypochondrial pain. So who are all the high risk groups? Young mother, old mothers, obese mothers with BMI of more than 35, and previous history of preeclampsia or family history of preeclampsia, primary mothers or those with new paternity, and past history of renal or connective tissue disorders. So these are all the cases who are prone to have preeclampsia in the pregnancy. To understand the pathophysiology of preeclampsia, let's see what happens in a normal placenta. Here we have the image of a baby connected to placenta through the umbilical cord, which is in turn attached to the decidua bassalis layer of the uterus. Placenta has two sides, the side facing the baby called the chorionic plate and the side towards the uterus called the decidual plate. The chorionic plate contains numerous villus and intervillus space. The fetal circulation is brought in through the umbilical cord inside the villi, and the maternal circulation is brought in through the spiral arteriole transversing through the decidua bassalis. So the maternal and fetal circulation meets in the intervillus space where exchange of gases takes place between the mother and the baby. Going to the development of the placenta, it takes place in stages. During the 5th day, the embryo is implanted into the uterus. The blastocyst differentiates into embryoblast that forms the fetus and trophoblast that forms the placenta. So the placenta is made up of two types of cells, that is cytotrophoblast and syncytotrophoblast. Cytotrophoblast forms the inner layer of the chorionic villi, whereas syncytotrophoblast forms the outer layer. During the development, the inner cytotrophoblast migrates from villi into the decidua bassalis and is called as the interstitial cytotrophoblast. From decidua bassalis, it slowly migrates into the arteries that transverse the decidua bassalis called the spiral arteriole, and this is called as the endovascular cytotrophoblast. So the interstitial and the endovascular cytotrophoblast together forms the extravillous cytotrophoblast. The process in which the cytotrophoblast invades the spiral arteriole is called as vascular remodeling, where the musculature of the spiral arteriole is broken down. Thus, the tone of the artery is reduced, leading to low resistance, high flow channel. The blood flow from the mother to the baby increases because of this high flow vascular channel, thus improving the placental perfusion. This vascular remodeling takes place in two phases, one at 12 weeks, where the spiral arteriole in the decidua bassalis is invaded, and one at 16 weeks, where the artery in the next layer, that is the inner 1/3 of the myometrium, is invaded. Let's see what happens in preeclampsia scenario. There are various postulated theories for pathophysiology of preeclampsia, which is unclear. The most common theories are genetic theory, which says that the gene that codes for anti-angiogenic factors, which are found in chromosome 13 and 12q, are affected, or the immune maladaptation theory, in which the tolerance between the natural killer cells of the uterus and the human leukocyte antigen of the placenta is affected. All this leads to abnormal vascular remodeling. That is, it leads to abnormal trophoblastic invasion. This is the reason for pathophysiology of preeclampsia. So, abnormal trophoblastic invasion, especially the second wave, leads to a narrow spiral arteriole, which in turn causes reduced uteroplacental blood flow, causing placental hypoperfusion. So when placenta is hypoperfused, it starts releasing a lot of inflammatory mediators that is released not only in the placental circulation but also into the whole of maternal circulation, causing endothelial dysfunction of the arteries of various organs in the mother. So let's see in depth for the postgraduates what happens here. So the inflammatory mediators causes increased release of anti-angiogenic factors like SFLT1. So this SFLT1 is an important factor that predicts the severity of preeclampsia. And there is also a decrease in pro-angiogenic factors like VEGF, PLGF. On the other hand, there is release of cytokines, interleukin-1, TNF-alpha, that all causes oxidative stress. So together, this leads to endothelial dysfunction. So endothelial dysfunction is the centerpiece of pathophysiology of preeclampsia. So what are the consequences of endothelial dysfunction? So there are three different kinds of sequelae for this endothelial dysfunction. One is a vasospasm sequelae due to prostaglandin and thromboxane A2 imbalance. Two, there is leaky capillaries, that is due to increased capillary permeability caused by the defective endothelium. And three, there is thrombotic sequelae caused by platelet aggregation and fibrin deposit, causing clot formation in the area of this defective endothelium. So let's go in detail about each sequelae. Due to vasospasm sequelae, there is vasoconstriction of blood vessels throughout the body. So, seeing the organs from head to toe, there is vasospasm of retinal vessel that causes retinal ischemia. This causes blurring of vision. In severe cases, there can even be retinal detachment. There is hypertension, which is a direct result of this vasospasm sequelae. Increased peripheral vascular resistance can cause left ventricular dysfunction in heart. The vasospasm and ischemia in the liver circulation can cause hepatic necrosis, causing raised SGOT, SGPT values, which is twice that of the normal limit. In severe cases, there can also be this periportal hemorrhage causing stretching of the liver capsules, which causes right hypochondrial pain or epigastric pain. In rare cases or in severe cases, there can even be hepatic rupture. Vasospasm of the spiral arterioles in the uterus can cause abruptio placenta. Second, what happens in the leaky capillaries? Leaky capillaries are due to increased capillary permeability in the systemic circulation. The leakage of the intravascular fluid into interstitial compartment in brain can cause cerebral edema. This causes confusion and drowsiness in this preeclampsia patients. In the lungs, it can cause pulmonary edema. In kidney, the increased capillary permeability to protein can cause proteinuria. So leakage of the peripheral circulation causes pitting edema and in turn causes hemoconcentration inside the blood vessels. So in these women where the blood is lost during delivery or PPH, she loses more RBCs due to the hemoconcentrated blood when compared to a hemodiluted blood in a normal pregnancy. And thus the preeclampsia woman doesn't tolerate the PPH or blood loss well. So let's go to the last sequelae, which is the thrombotic sequelae. Thrombotic sequelae happens because of the platelet aggregation and fibrin deposit in the region of endothelial dysfunction. This can cause low platelet count, which is a characteristic feature of preeclampsia. There is microangiopathic hemolytic anemia picture that is called as MAHA, and which also causes elevated LDH. Factor 8, protein C, protein S are all used up. This can slowly lead to DIC picture in severe cases. There is also microvascular coagulation that can cause pulmonary embolism in very severe cases. Also, this kind of clots in the spiral arteriole can lead to fetal growth restriction or in severe cases, intrauterine death. Let's sum it up, especially for the MBBS students. The pathophysiology of preeclampsia is mainly due to abnormal trophoblastic invasion causing placental hypoperfusion, leading to release of inflammatory mediators that causes endothelial dysfunction. So these are the 4 important terminologies to be remembered. So let's see what happens in each organ. In kidneys, there is glomerular capillary endotheliosis, which means the endothelium of the glomerular capillaries are swollen, as shown in the picture. This leads to decreased clearance of creatinine and uric acid, increased protein permeability causing proteinuria, reduced GFR causing oliguria, and activation of renin-angiotensin system causing sodium retention. In severe cases in preeclampsia, there can be acute tubular necrosis or acute cortical necrosis. In liver, as we saw earlier, due to vasospasm and ischemic sequelae, there can be hepatic necrosis, there can be periportal hemorrhage causing stretch of liver capsule, there can be hematoma, and in worst case scenarios, there can be even liver ruptures. All this can lead to elevated liver enzymes, which is twice that of the normal limit, nausea, vomiting, right hypochondrial pain, or epigastric pain, which is the imminent symptom of preeclampsia. In eyes, there can be vasospasm of the retinal arteries causing retinal ischemia, or in worst case scenario, retinal detachment. This leads to, again, one of the imminent symptoms, which is visual disturbances. Also, leaky capillaries can cause papilledema in the eye. In CVS, there can be peripheral vascular hypertension, especially more than 160/110, can be hazardous to the women. There can also be left ventricular dysfunction due to increased peripheral vascular resistance. So in brain, there are 2 things that's happening. One is leaky capillaries again that can lead to focal or generalized cerebral edema. This causes drowsiness, confusion, lethargy in preeclampsia patients. Second thing is there is loss of cerebral autoregulation. So what is cerebral autoregulation? It is a protective mechanism in brain in which the blood vessels of the brain have capacity to constrict themselves to protect the brain tissue in case of sudden high blood pressures. So when this is lost in preeclampsia, there is cerebral hypoperfusion. This occurs mainly in the occipital and the parietal lobe of brain. So this is the cause of classical throbbing occipital headache, which is found in preeclampsia. There is also a cause of blurring of vision as occipital lobe is involved. Due to the cerebral edema and due to cerebral hyperperfusion, there can be release of excitatory neurotransmitter like glutamate that can cause convulsion, which is the final sequelae of preeclampsia. This is what we call as eclampsia. So the changes in the brain that especially occurs in the occipital lobe is called as PRES syndrome, which is posterior reversible encephalopathy syndrome. So this sums up our topic. I hope you got your concepts clear. So let's meet in the next video. Thank you.